Okay, so we're live. Welcome everyone to the Australian TGA Psychedelic Summit. I'm Jason, managing editor at Microdose, and I guess a little brief introduction as to why we're here. As you all probably know, in February, the Australia government announced the rescheduling of certain psychedelics. It was very big news, with MDMA and psilocybin going to be available for prescription by specifically authorized psychiatrists for the treatment of certain mental health conditions. So, with Australia leading the way on psychedelic medicine rescheduling, Microdose is bringing together some industry experts and thought leaders to discuss this historic move and what it means for patients in Australia and in the psychedelic sector as a whole. So, for our first session, this is the ethical implications of this rescheduling. And we're with Dr. Bianca Sebben.
Sebben, yeah.
Sebben. All right. Should have checked that before. All right. Welcome. Thanks.
Thanks
for being here. Yeah. Thanks for being here. So let's start with maybe a bit about your background and where you're coming from and why you care about this subject.
Sure. So I'm a clinical psychologist. I work mostly with complex trauma and dissociative disorders and Aboriginal and Torres Strait Islander people. So a PhD in Indigenous psychology, where I was looking at barriers to service use and access for Indigenous peoples, both in Australia and Mexico. So that's how I got into psychedelics in the first place. And so at the moment, I work in private practice, and I also do a lot of integration and harm reduction support for people working with psychedelics in the community. And I'm part of a working group that's created a culturally safe model of psychedelic assisted psychotherapy for Aboriginal and Torres Strait Islander people, and the board member for credentialing for the newly formed Australian Multidisciplinary Association for Psychedelic Practitioners.
Okay, so you're deeply involved in this space. Are you currently working with clients there? I mean, I'm assuming there's some ketamine therapy happening in Australia at the moment. Are you involved in that space?
Yeah, so there are some people that are doing ketamine assisted therapy, but it's still very, very few people. A lot of what's happening here is more of like your IV infusions that are happening, not necessarily within the context of a assisted therapy protocol. So outside of clinical trials, there really isn't too much happening yet at this space, just a little bit of work with ketamine.
Okay, all right. So your concern here, I guess you're passionate about how this is going to roll out for accessibility, for some of the ethical implications of it. What are you really focused on?
So there's a lot of things that still need to be worked out before July 1 rolls around. And in Australia, we've got to keep in mind we don't have any accredited therapist training programs as such yet. We also relatively new in the trial space. So in terms of therapists that have experience in being a therapist in clinical trials, there's still only a handful of people in Australia that have that experience. And so actually having therapists that are not only trained in psychedelic assisted psychotherapy, but complementary treatment protocols given or modalities, I should say, given this is going to happen in a community context, not in a trial context. There's liberty to take longer to do good preparation and good integration within the context of a therapy framework. So we need people that are trained in trauma therapies to be able to do this, particularly say with MDMA for PTSD, that kind of thing. And then also the accessibility in terms of the cost of this treatment. There's been lots of numbers thrown around at the moment, particularly because we don't have an approved product available here in Australia. All the medicines will be imported at this stage. So when you add up the cost of importation, you add up the cost of to therapists and their time. Lots of big numbers are being thrown around at the moment, and we don't know how that will look in terms of private insurance or our Medicare program. That's unlikely to be covered in any way whilst this is very new. And also in terms of psychiatrists becoming authorised prescribers and submitting their applications to a human research ethics committee. There's lots of, I guess, consultation going on at the moment with the TGA and the Psychiatry College Steering Committee. They are proposing certain requirements for authorised prescriber, and most recently, it looks like it's being proposed that in order to become an authorised prescriber, you have to have experience dosing at least one client in a clinical trial. And so when you look at the fact we've only got a few trials off the ground here in Australia, that probably leaves a handful of psychiatrists, maybe 4 or 5, that would actually meet that requirement at this stage. So those guidelines are not set in stone yet, but it's in terms of what steering committees are considering. In the most recent webinar I attended, it was proposed that an authorised prescriber would need experience dosing a client in a clinical trial setting.
So a lot of kinks to work out from different levels.
Mm-hmm.
Yeah. And all of those are going to affect access eventually.
Absolutely. I guess in terms of being involved with a psychiatrist that can become an authorised prescriber. At the moment in Australia, getting into psychiatry is near impossible. There's wait lists of, I heard today someone's on a 2-year wait list in order to get an assessment. Some people I know that might be taking on new clients still have a 4 to 5 month wait to see new clients. So if you're not already involved or linked in with a psychiatrist or a psychiatrist that has clinical trial experience, then it's unlikely that this will be very accessible at this stage.
Mm-hmm. So just in general, for access to therapists in Australia, there's a backlog?
Massively, both with psychologists and psychiatry. So for the first time in my life, even if I get referrals coming through to me, I really don't know people with open books that I could refer on to at this stage. It's been really, really crazy out there in terms of the demand for services, particularly post-COVID. And psychiatry, I would say, is even worse than that in terms of trying to get in to see somebody in a timely manner. Yeah.
Okay, so there's already a backlog of access to therapy options, and now we're going to ask create a subset of therapists that have this particular skill set to be able to help people with psychedelic assisted therapy. So the bottleneck of therapists is already there.
Yeah, absolutely. And then, very few therapists as well have undergone any type of training in psychedelic assisted psychotherapy. So there are certainly training programs out there, and people have completed various forms of training. However, nothing at this stage has been credentialed as being suitable or approved, I should say, that covers all bases in terms of actually training to be a licensed psychedelic assisted psychotherapist. So that's something that we've tried to address by forming the Australian Multidisciplinary Association for Psychedelic Practitioners. And so my subcommittee is in charge of developing credentialing guidelines, both for practitioners and proposed supervisors of those practitioners. So at some stage, we are hoping to work with the college and the steering committee and propose a way around that in terms of a way people might be able to demonstrate that they've met those credentialing standards through different types of training that they have already completed, until such time as a training program in Australia is created that meets all the credentialing standards.
Mm-hmm. So tell us a little bit about that organization that you're working with now.
Mm-hmm.
Could you?
So, yeah, the Australian Multidisciplinary Association for Psychedelic Practitioners was formed following the announcement from the TGA to reschedule MDMA and psilocybin. And it was formed by a group of practitioners here in Australia, very multidisciplinary, from GPs, psychiatrists, psychologists, psychotherapists, social workers, that either have a keen interest or have experience working as therapists in clinical trials, or working with ketamine in the community, or providing harm reduction and integration support already in the community to people who have worked with psychedelics themselves or in other contexts. And so we formed various subcommittees to look at things like clinical governance, stakeholder engagement, credentialing, those kinds of things, in order to start to build a bit of an infrastructure around this. So we've all been working very hard to get this up and running, and hoping to connect with the TGA and the Psychiatry College Steering Committee to put forward our recommendations based on the consultation we've done with people both in Australia and overseas, so that we can make sure that our credentialing standards here are in line with international standards as well, but also adapted to the Australian context. Myself in particular, having an interest in working with Aboriginal and Torres Strait Islander peoples, and making sure that any treatment that is available can be available in a culturally safe and accessible manner as well. And so that's a big part of the work that we hope to do with AMAP as well, is to really make sure that this is a multidisciplinary approach, and that our colleagues of other disciplines, not just psychiatry and psychology, have their expertise acknowledged and included in developing these standards as well.
Mm-hmm. Okay, yeah, that's important work. It seems as if a lot of the foundation really needs to be built out, and
Yeah. Mm-hmm.
yeah, this is I guess virgin territory over there. A lot of that infrastructure needs to get built. So all of those avenues seem super important. So it's great that you're working on it.
Mm-hmm.
I guess when July 1st hits, I want with so little of the pillars built out. I wonder what's going to happen. Is there an approved prescriber that we know of?
Not that I'm aware of, because I think some of the human research ethics committees are still meeting and even designing things like templates for people to submit their applications. I am aware of some people that have submitted applications already, and essentially it's like submitting a proposal for a clinical trial with a participant number of one. So you can't. It is quite a challenging process to go through if you're not an academic researcher and have that knowledge in submitting proposals for research. So I'm curious how it's going to be for people that want to become an authorised prescriber that don't have that background. So, yeah, people still need to be submitting those proposals to the Research Ethics Committee, but then ultimately the TGA will see those applications and will still have the liberty to deny or decline something if a proposed protocol is not appropriate or not robust enough, those kinds of things. And so there may be a couple of people with authorised prescriber status by July 1. However, with this most recent webinar I attended where a member of the steering committee suggested that an authorised prescriber would need to demonstrate experience having dosed a client in a clinical trial setting, I'm unsure if any of those people would actually meet authorised prescriber status. I'm not sure how much influence that steering committee has or how much influence the TGA will have to override that. That's not really an area I know or understand. However, just based on that particular webinar, it sounds like it might not be that easy to become an authorised prescriber if you don't already have clinical trial experience.
We just had an attendee chime in. We got Roy Gustini saying that the TGA has stated that approved prescribers will not be approved until after the July 1st.
Sorry, that's true. Some people have submitted applications already though, but yes, it won't be known the outcome until later. Yeah.
All right. Thank you, Roy. I was going to mention that we do have a good number of people in session right now, and feel free to submit questions into the platform if you have any questions. So, other than the mention of potentially needing clinical trial experience, do we know of any of the other criteria? Is it going to be that strict? Will it open up to people with less clinical experience, or what do we know about that?
Well, it will need to happen within a multidisciplinary team. So that will include psychologists, psychotherapists, etc., who will be conducting, I imagine, the preparation, integration, and ongoing therapy sessions. But to the best of my knowledge, it hasn't been stipulated that therapists will need to have clinical trial experience. However, we would certainly hope that these people have undertaken some kind of training in psychedelic assisted psychotherapy and have a background knowledge of working in this way, which is, as a clinical psychologist, it's very different to how your standard psychology training teaches you to work with clients, especially in a dosing session that's very non-directive, etc. That's a specialized skill that would need professional development in order to learn to work in that way. So the other thing at the moment is where this will occur. So again, it looks like this will be only occurring in a licensed facility, so something like a hospital or a healthcare clinic. I don't know if it'll be able to happen in, say, a private psychiatry practice or a private psychology practice. It looks like it's going to have to be in a licensed facility. And so I guess for myself as a therapist, that leads me to think about things such as set and setting and the impact that being in, say, a hospital setting or a clinical, another clinical facility may have for the client in their experience of undertaking that treatment, because we know set and setting is very important. So how they will really work with that within a hospital setting may be challenging as well. So that means, I would assume that unless you're a psychiatrist that is connected to some kind of licensed facility like a hospital or a healthcare clinic, that doing this treatment would be quite difficult. So like for private psychiatrists, for example, unless they've had somewhere to conduct this outside of a private treatment room, I'm not sure that they would be able to prescribe as well. So, but yeah, this is very clear that this is not about just prescribing the medicine. It's about a robust treatment protocol involving therapy that is proposed to the Human Research Ethics Committee. So that means the psychiatrists cannot work by themselves, essentially. They need to have a team around them. And it looks like at the moment most protocols will have to be pretty identical to what is currently happening in clinical trials, keeping in mind that there will likely be adaptations being in the community. So, for example, why should we limit someone to 4 integration sessions, for example, if the whole purpose of this is doing ongoing therapy? We shouldn't have the same limitations, hopefully, in that regard that there are in clinical trials. So, that will all become part of their proposals, where they plan to do it, who will be involved, and what, the entire treatment plan will look like.
Right. Yeah, and all of these kind of backlogs eventually will affect access and cost. If we're this slow in rolling things out, then and you have 3 therapists in the whole country offering services instead of 30 or 300, costs are going to be that much more prohibitive, I'm assuming, and that spills all to patient eventually that hurts patient access. Yeah.
The other thing is as well that I believe the TGA have stipulated that the psychiatrist has to be the one to dose the client. So at this stage, and I guess this will need to be determined by the steering committee and AMAP and TGA coming together to really work this out. But we're unsure if the psychiatrist will need to be present for the whole session, or if they will simply come in, dose the client, and then leave. In terms of the credentialing, we've proposed with AMAP, we don't really see the need for the psychiatrist to be there for the whole session. We've proposed different types of therapy dyads that could exist that would meet the needs of the client, but also safety and monitoring of any medical issues, those kinds of things. Because realistically, the cost of having a psychiatrist in a session for 7 to 8 hours, if they're billing at their usual rate, would be astronomical. Whereas the cost of a psychotherapist or a paramedic or a nurse is going to be much less. So I guess the cost is also going to depend on who needs to be present in the dosing session, but then also with our insurers and our Medicare system, will we be able to put the preparation and the integration sessions through Medicare like we would with seeing regular clients? Because in Australia, you get a rebate for seeing a psychologist, anywhere between $90 to $140 back for your session. So that would obviously reduce the cost to the client if they can get some money back from Medicare for the prep and integration sessions. And then if the psychiatrist didn't have to be present for the whole dosing session. In saying that, I've had some conversations with psychiatrists that would be, they're so willing to get this out there that they would be willing to reduce their fee. If they're allowed to bulk bill in certain circumstances, they would as well. So, I want to put that out there, that there's some wonderful psychiatrists here that are really willing to do whatever they can to make this accessible as well. But because as well, it would have the 2 therapists in there. We would need to be modelling what's happening in clinical trial protocols. So the cost of 2 therapists for, 7, 8, however many hours, I've seen numbers being thrown around from anywhere to $10,000 to $25,000 for this treatment.
Yeah, that's a bit prohibitive. Are there protocols or kind of precedents in terms of ketamine therapy in Australia right now that a psychiatrist prescribes it, but are they sitting through the whole session, or is it nurse practitioners that are able to sit through ketamine sessions instead of it? Do we know anything about some precedents with ketamine?
Yeah, so there are different people working in different ways depending on the setting. So, there are people that have, if they're having an IV infusion, they may have a nurse practitioner there with them. There are other people that might be working with a medical officer that has the ability to prescribe and also has therapy training and might be working in a more ketamine-assisted therapy way. And there are also other people that are developing protocols and working in more of a ketamine-assisted therapy way at the moment with psychologists or say mental health accredited social workers engaging in the therapy component of that. So that there's still people developing various protocols as well, but that seems to be a bit more open in terms of who can be involved, because it's not just psychiatrists that can prescribe ketamine, is my understanding. There's also medical officers that are prescribing or have prescribing rights for ketamine that can work in that way as well. So, and then of course social workers with mental health training being involved, etc. It seems to be a bit more flexible.
So there's more flexibility, it seems, with ketamine therapy at the moment than what they're proposing for this new rescheduling.
Yeah, so I don't have a lot to do in the ketamine space, but I certainly have clients that are attending hospitals to get infusions, and they have a quick chat to the psychiatrist, and that's pretty much the only involvement they have with the psychiatrist. It's then handed over to the nurse to take care.
Would that be a good case to present to the TGA, that it's been successfully rolled out with a slightly less stringent criteria?
Well, we certainly want to draw on the expertise and the knowledge of people that are working in that ketamine-assisted therapy way in the community already, and present that to the TGA as well, because they have obviously some great experience, the do's and don'ts, even down to set and setting, safety procedures. Obviously, the way that ketamine is stored is very important, and so they're already accustomed to meeting all of those requirements as well. So yeah, I think it's really important that the TGA liaise with, and the steering committee as well, people that are already doing this work with ketamine and have addressed some of these hurdles in the first place, and also have very robust protocols in place for client safety, preparation, and ongoing integration as well. So yes, I would really hope that they will reach out and draw on that expertise that's already available in the community.
Yeah, definitely. Yeah, thanks for all that. We're winding down here. A couple of questions. We have Crystal asking about if the timeline is realistic. It seems like July 1st is, it's a date, but it doesn't. It seems like we're quite far out. So yeah.
Yeah, and I guess there's a lot of apprehension about that timeline as well. Many people are really glad and excited to be having this conversation and getting things ready, but the infrastructure isn't there yet. I really don't think that as of July 1, we're going to have people lining up to receive their MDMA or psilocybin. I think it's going to be a really slow rollout, and that it's important that we take the time to do this properly rather than be so attached to that July 1 guideline. I think it's very wise that it's rolled out slowly and gradually. And so I'm not particularly concerned that as of July 1, we're going to have everything sorted. It's just, we're better off to take our time and get this infrastructure established and do things properly, because what we do here is going to impact what happens elsewhere. And, you know, so we have that responsibility to hold as well.
I totally agree, and it seems like you're doing good work, and you're covering the bases, and building this foundation. So slow and steady wins the race.
That's right, exactly.
All right, I appreciate it. You have put a link to your organization there in the chat for anyone who wants more information. Anything else? Closing comments? We're at the time now.
No, just thank you for having me and for your interest, and watch this space and we'll see what unfolds over the coming months.
All right, I appreciate it.
No problem.
We'll check in a few months for an update.
Wonderful. Thank you.
Thank you, Bianca. All right. Stay tuned.